Well, thank you. I'm honored to share the stage with you, Rosemary. Tell me, to start with, what made you write this book?
Well, I got started in this, Jenny, a number of years ago, writing about healthcare. I started writing about medical mistakes in a book called Wall of Silence. And then I sort of migrated to understand why medical mistakes were happening. And then I stumbled on this topic of overtreatment, that there's a lot of people who are getting unnecessary surgeries, CT scans, and other tests and procedures. And then, health reform was happening. So then I started writing about healthcare reform and the role of the healthcare industry and how it shaped that policy process. And then finally I stumbled upon, Medicare. Medicare is something that we are all going to be on together. We all have a stake in Medicare's outcome. So I thought it really timely to take a different look at Medicare. The stories that we don't see about Medicare in the mainstream media for the most part, to understand what's really going on. Because here, just a few blocks away on Capitol Hill, decisions are going to be made this year and the next number of years that could have a profound impact on the shape of that program, and that in turn will affect us. So as part of a vigorous democracy, the public has a right to know where the money comes from to pay for Medicare, where it's going, and how it's being used. And it's amazing what happens when you start asking these questions and trying to answer them. And that's what I tried to do in Medicare Meltdown.
I really enjoyed the book.
Thank you.
And I was struck, of course, by the fact that Wall Street is involved in every industry, to speak of. Why should healthcare be any different from airlines, food safety, anything else? What sets healthcare apart from the grocery store?
I was just talking with some of my nursing colleagues here this evening, and we're talking about how when you become a physician or a nurse, your primary duty is to patients. And yet we're seeing a lot of physicians and nurses today who are working in organizations whose primary duty legally is to investors and to others. They're not to patients. And that creates some really profound tensions and ethical dilemmas for physicians, for nurses. And so the other thing that's interesting, when Medicare was started back in 1965, there were no healthcare companies on the Fortune 100 list. And now there's 15 of them. And so there's bound to be some impact on our healthcare. And what is that impact? And of course, we just don't look at the for-profit aspects. We look at general trends in healthcare and Medicare Meltdown. But there's some really interesting things that you come across, and that's why I tried to write about in Medicare Meltdown.
We just are now implementing a huge overhaul to the nation's health system. Did that law get anywhere towards addressing some of these issues?
Well, certainly it's going to make access to care and insurance available to many, many more people. But, I wrote that book on health reform, The Battle Over Healthcare. And what was so interesting, and we'll get to Medicare in just a minute, but this is really interesting about healthcare. If you recall, when the healthcare reform debate was unfolding, we were going through this terrible financial crisis. Remember the housing bubble that burst. And the banks were, what they were really doing with our money, and how people were getting mortgages that never should have gotten their money. So I'm writing this book on health reform, and here's this din in the background. So I sort of came to the conclusion, price bubbles. Don't we have them in healthcare? We have toxic assets. What about Avandia? What about metal-on-metal hip implants? Aren't those a form of toxic assets?
So when's the bubble going to burst?
Too big to fail. Privatized gains and socialized losses. I'm looking at Al Levine from Public Citizen and others in this room who've worked on patient safety and medical errors and hospital-acquired infections. Aren't those a form of privatized gains and socialized losses? That people are harmed? Who pays for the cost of it financially? And who pays for the cost of it as humans? In many ways, and I've written a book on overtreatment called The Treatment Trap. And, people were getting mortgages that they never should have gotten because they were just totally inappropriate. And boy, don't we have that in healthcare? people having back surgeries and heart bypass surgeries that they never should have, overuse of stents. So I couldn't help but notice these parallels. And I think it's important for us as consumers of healthcare, I'm looking at Robert Krugoff from Consumer Checkbook, that we see sort of what are the forces that are shaping our healthcare that affect us every single day, all of us, as families, as employees, so on.
So does the ACA do anything? I mean, they did make some cuts in Medicare. They said they were going to save money in certain ways by changing the way payment was tied to quality, et cetera.
Right.
Are those going to be effective? Are we seeing sort of the bubble maybe starting to decline? I mean, we have seen healthcare spending, for example, go down a little bit in the last couple of years.
Right. The rate of growth in Medicare spending has modulated a little bit. But, you know, I have a really boring life, so one night I was looking at the Medicare Trustees Report. Page 103, the 2011 Medicare Trustees Report.
Okay.
And it's fascinating what you'll find out. And I have a little line graph in Medicare Meltdown. In 2011, an average person who earned an average wage over the course of their life, when he or she retired, again, this is average, so not everybody will have the same experience. 27% of that person's Social Security check will be going to pay for Medicare Part B and Part D premiums and co-payments. That's an enormous chunk of Social Security. And then, if you play that out, in 2082, 46% of the average person's Social Security check will be spent just on Medicare Part B and Part D. So when I'm 90 years old, and that doesn't include the Part A hospital co-payments and deductibles. So we're seeing Medicare take an increasing share of older adults' income, just as we're seeing as employees. And this, of course, assumes that there's no change to the cost of living adjustment in Social Security that President Obama has proposed, the changed CPI. So if we say it's modulate, growth might be modulating, the fact is there's a trajectory here that is so astonishing. And meanwhile, people are proposing, President Obama has in his 2014 budget, let's increase the Medicare premiums for high-income seniors. Well, where's that going to take us? Huge proportion of Social Security checks going to pay for Medicare. It's a huge story that I think we've just not been aware of that needs to get out. And that's why I wrote Medicare Meltdown, so people can really see what's going on.
Okay, so if the ACA isn't going to change the trajectory alone, then what is the solution? What does need to be done?
Well, the ACA did have the Independent Payment Advisory Board, and that was like the base realignment and closure commission to take it out of the hands of elected officials. Because elected officials, it's going to be very hard for them to close a military base in their community that they represent. So the idea was, we know the same is true in healthcare. It's very hard for elected officials to say no to hospitals and other healthcare industry actors in their community. And so let's find some experts to make recommendations. In my view, I think there was a lot of misinformation about the Independent Payment Advisory Board. It was portrayed in the media as being something that, our elected officials are being taken out of the equation. That was actually not true. This Independent Payment Advisory Board was all about an independent group making recommendations. So it was up to Congress to accept them or to reject them. And if they accepted them, fine, it was Congress's decision. If they rejected them, Congress would still have to come up with its own recommendations on how to achieve those level of cuts. But now we know that the Independent Payment Advisory Board was repealed in the House. And it certainly has not gotten off the ground, as Kaiser Health News and others have reported. And it was unfortunate that it was portrayed as rationing, when it was really an attempt to try to mitigate this trajectory that we have for Medicare spending, which there's really no end in sight.
So the iPad might be a solution?
Well, the approach of trying to come up with ways to limit the rate of growth in spending. And the other thing that's interesting is both Democrats and Republicans, Paul Ryan and President Obama, have both proposed limiting how much Medicare can increase per beneficiary to growth in the economy plus a certain percentage. And I never thought I'd say this, but I think we do have to impose some limits. You can't have a system without any limits. And that's what we have in healthcare today. And as you'll hear more about, I'm sure, in a few minutes, there's so much waste in Medicare. 30% of Medicare is lost to overtreatment and fraud and inappropriate use and misuse of resources, there's plenty of money in there. So we have to find a way to make the system sustainable. And just increasing premiums and raising the eligibility age from 65 to 67, in my view, that there's a better way to do it.
And that solution, as you say, might be placing some caps.
I think setting some limits to how much Medicare can grow, but then the public has to be vigilant to make sure that that money is spent appropriately. Otherwise, we could really be older Americans could be at a disadvantage. But I think a main theme that I think is so important to get across is the amount of money that's wasted in Medicare that's not spent on older adults. I'll tell the story. I work with a number of physicians in my work, and I met a wonderful pediatric neurosurgeon who decided that he needed to be a better steward of healthcare resources. And this is just one example of one physician. So he went back to his hospital and asked the financial office to send over someone to tell him how much the supplies in his operating room cost, because he never knew. He never knew what was in that closet. And so he learned that there was $700,000 worth of supplies in his OR. And he said, I only needed half of that. And 10% had expired and had to be thrown away. $70,000 in one OR in one hospital. And then he learned through one of his patients, he was being a pediatric neurosurgeon, he meets a lot of parents. And one of the parents said, I work with a lot of teaching hospitals, and the inventory control is as disorganized and chaotic and wasteful just as it is that you observed in your own hospital. So this was not an outlier. It happens in many, many institutions around the country. And you have to go upstream about why that is the case in the whole non-competitive, wasteful model of how hospitals buy equipment and supplies. The other part of the story is he went to buy a piece of ultrasound equipment. And he found it online for 10% of the cost of what the hospital was paying for it. It's because of that market, for the $200 billion market for how hospitals purchase stuff is non-competitive, non-transparent. And I say if I'm nonpartisan, but if Republicans want to have competition and price transparency, where we need to have it is in that wholesale market. That's where 8% of total healthcare spending goes, and it's a huge black box. And if I may say, they got an anti-kickback exemption from Congress in the mid-1980s, and there's a lot of hanky-panky that goes on there. But that's anti-kickback exemption from Congress. Yes. So this is and the Washingtonian has written about this, but it's so politically charged. The forces are so powerful. But I think the only pushback we have is an informed democracy of informed public saying, hey, wait a minute, we're already paying enough. Why should we be paying more when so much of it is misused and not being used properly?
It's a little bit frustrating when you think about how many people are profiting in the healthcare industry. You list the group purchasing organizations, you've got the medical device manufacturers, the hospitals, the doctors, the insurers.
Right.
There's so many uber powerful industry people with a lot of money to spend on lobbyists. We just saw the gun control debate happen in Washington, where you had a public that 90% of them agreed. I mean, I don't know that we're going to get 90% of the public to agree on anything about healthcare, and yet we didn't get the law. The law didn't really go anywhere in the Senate so far. It's how can the public and consumers sort of address these issues in the face of such intense and such powerful lobbying efforts from the industry? You know
where I think we have a burning platform right now? I'm sure many of you saw the Time magazine article about healthcare costs, and that had 225,000 Facebook likes. I was giving a talk in Maine a couple of weeks ago, about 760 people in the Civic Center, and I asked, how many of you want to have price transparency in healthcare? And this is a group that consisted of hospital executives, physicians, as well as members of the public, community health workers. And where I was standing, about almost every hand went up. So I think one place to begin, and there's a lot of opposition from the healthcare industry about having price transparency, and it's technically has some challenges, but you have to wonder, in our consumer society, why is there opposition for us to know in advance how much something will cost? So I think, and you have kids who are 10 years old who know how much iPads cost and how much the data plans are for this gigabyte and that gigabyte. I bet we could figure this out. So where I think we have some momentum is there. And we published in JAMA Internal Medicine a piece about Senator McCaskill, who went in for knee surgery. And she said she called 3 hospitals to find out how much it was cost. And she said, I'm a U.S. Senator, and I couldn't find out. Now, personally, I would rather have information on quality and patient safety out there for the public. But given the reality, I think what will bring Americans in to begin to push back on this profligate system is a push for and a requirement for price transparency. I went back and looked at the history, and if you've all bought cars and you see that MSRP sign that's in the window of every vehicle, how did that happen? It was a consequence of legislation in 1958 by an Oklahoma member of Congress that required price transparency because there were a lot of shenanigans that went on in pricing. And so it's all the same. It's all uniform. And then came, quality and consumer reports looking at the quality of vehicles. So I think we have a moment in time to take advantage of the public's deep concern, especially since a lot more people are paying for health care out of pocket now. And their jaw. I was coming over on the metro here tonight, and I was talking with a woman, and she says, yeah, I went to get some medication for my dad who's on Medicare, and I was shocked. It was $700. Why can't people know the price ahead of time? So I think if you have broad public sentiment, if we can capitalize on that, and I believe there's some legislation, I haven't looked at it, that's been introduced calling for price transparency in healthcare, and I think that would be a big step forward.
Taking it down to the individual consumer level, is there anything an informed consumer can do at this moment if Claire McCaskill can't figure out the cost of her ultrasound? Is there some way for consumers to take matters into their own hands when it comes to their health?
I think we have to try. So I was on a panel a couple weeks ago with a woman who was going for surgery for cancer. And she was a savvy consumer. She's a retired nurse. And she called 3 hospitals to find out, what is your infection rate? Isn't that interesting? And 2 of the hospitals actually told her. And the 3rd hospital says, well, we don't have to report that. Not until next year. And her reply was, well, I have cancer this year. So what are you going to do? So, and she publicly said, well, I just decided that I'm not going to that hospital. If they can't tell me, because this is my health and my life, the quality of their outcomes. So I think we're at an early stage of consumers becoming much more savvy, but calling up and demanding this information because we have a right to know, not only about price, but also about quality. And I'll tell you, I was looking at the history of informed consent in medicine and in healthcare. It's less than 100 years that the public had the right to consent to medical procedures. And it was only in the 1950s that we have a legal right to informed consent. So in the whole history of medicine, in a very paternalistic system, in the last 50 years, we have come a long way. But we have a long way to go. And even informed consent, it has a lot to be, a lot wanting right now. So this is a slow evolution, but it's never fast enough because these are sometimes life and death and, huge financial impacts. But at least we've started.
Can you tell us a little bit about what you think might happen in healthcare down the future if we don't do something? You have a really wonderful metaphor that I'd love you to tell here about the airline industry.
Oh, you'll have to remind me of that one.
I believe it was that there was a shift towards different consumers having different experiences of healthcare, much the way you would sit in first class or the middle seat, which is
right. Yeah. I said, how you have a lot of advertising for the very high-end airline seats, particularly for overseas travel. That I think a lot of us, though, are going to be in the middle seat and hanging on with a lot of turbulence, packed in like sardines. But I think the long-term trajectory is really a huge challenge. I was flipping through an old CBO report, Congressional Budget Office report, that from 2007, and on the last page in Appendix D, there was a graph that showed where we're headed in terms of total healthcare spending as a percentage of GDP. And if we keep doing what we're doing, again, this was before health reform, in about 2082, we'll be spending 99% of our GDP on healthcare. And if you look at, look what's happening already. In my town where I grew up, in suburban New York, I was on their website, and last year they closed the grammar school I went to. 2 schools, actually, in our school district in a town of 30,000 people. And in part, that's declining enrollment, but there were also budget cuts. Again, still in the post-recession period, the state aid has gone down and so forth. So that was 2 years ago. This past year, what happened was they had to cut 15 teachers. And what was going on in that town of 30,000 people? Healthcare spending for the school district had gone up 27%. So if this year they're cutting 15 teachers, what are they going to do next year? And the year after that? When I was up in Maine, I said, where's the money going to come from to plow the streets in winter? These are essential public services. And so these decisions are being made. We're making these trade-offs implicitly and invisibly as more and more money is consumed by healthcare. So that's where we're headed, and that's why I think we need some sort of limit, some sort of red lights in a system, because we can't have a country without red lights.
You spent a lot of time in the book describing hedge fund and financial industry involvement in healthcare. For example, in for-profit companies with shareholders, buying up hospices, and their motivation changes, and they start putting healthy-ish seniors in those homes, people who aren't necessarily on the verge of dying, which is what hospice sets out to do.
Right.
But you don't spend a lot of time focusing on nonprofits. Right. And I was sort of struck by that, because in my own reporting, I find a lot of bad actions by nonprofits as well. I wonder if you could sort of comment on that. Do you think that nonprofits generally tend to have a better outcomes, better quality, better spending, or do you think they're also a problem?
Not necessarily. But the thing about the hospices that I found so extraordinary, I worked in the field of palliative care when I was at the Johnson Foundation. We helped hospitals establish palliative care programs, 1,600 hospitals, and we helped to build the field of palliative medicine. And I was so struck to go back when writing this Medicare Meltdown book about what's happened to hospice care. It was started by the dean of the nursing school at Yale, Florence Wald, and it was started as a mission. It was started by people who volunteered, people in the community, social workers, nurses, physicians, who went to care for people who had cancer, for which there was no cure, and chemotherapy was just not going to work. And so they just did it, because it was the right thing to do. And then you see how it's gone from a mission, and it became a business. And there's nothing wrong with business. It helps organize human and financial resources to accomplish an important aim. But then I was looking at what's happened, and thanks to Kaiser Health News and Bloomberg, who were reporting that there's a whole number of some of the largest for-profit hospices in the country that were found by the Office of the Inspector General in HHS to have been doing things such as enrolling people in hospice who are not dying, and that they were incentivizing their employees. They were setting enrollment targets for employees about how many people they had to enroll, and their job performance, and their jobs were on the line to meet those enrollment targets. And some of the things that these employees were doing were going out to public housing projects to try to find people to enroll in hospice. They were going out with Meals on Wheels volunteers, trolling for patients as a way of so-called outreach. If Florence Wald were alive today, look how it's evolved from a mission to a business to what I call a racket. And I wanted to bring home the trail of money. So we have hospices that are doing this, and these are big ones. These are some of the largest ones in the industry. And so they have lawyers who are defending these things that really are indefensible, and they've all settled with the Department of Justice. But who's paying for those lawyers for these hospices? Well, let me tell you, I just paid my income taxes, and if you're paying the Medicare payroll tax, a little piece of that is going to pay for hospice care, and a little piece of that is going to pay for some of these lawyers that hospice has hired to defend the indefensible. This is what's happening to our money. And I think the public has a right to know. And it's not just for-profits, but it just so happens that these things, it's really interesting. And then you have some private equity firms that are investing in hospice. Now, private equity can perform a really important function in our financial system. They can bring needed capital to turn around a business. They can bring management expertise. But I have to ask the question, hospices are an activity that doesn't require capital because it's really a labor-intensive activity, and the biggest limiting factor is labor, finding enough nurses and caregivers. And is there any special management expertise that's needed? So you have to ask the question, is society getting any benefit from investors that are coming in that are just, frankly, taking out money? You know, a market economy works when there's an exchange and both parties benefit. And I have to ask the question, is society getting a benefit from those investors who are coming in and taking money from the system? They might in some cases, but from my assessment of what's going on in hospice, to me it poses more questions than answers.
Just to make sure we're spreading the blame around, and then there's plenty to go around.
Sure.
Let's look at the Washington, D.C. market right here. You've got two nonprofit hospital players, Johns Hopkins and MedStar, and both of those groups are vying to be the one to build a proton beam therapy center that's going to range from, I think it's $39 to $150 million. I don't know if you guys know proton beam therapy, but in order to make one work, you have to have a building the size of a football field that's all cement. And the therapy itself is fairly questionable. We know it works for some childhood cancers, but it's being used for a lot of other things, prostate cancer among them, breast cancer, that head and neck. We don't necessarily know that it's any better or even as good. And what we do know is it's a whole lot more expensive. And yet you've got these nonprofits trying to build them anyways. I mean, what do you make of that? And how can we even begin to get payment under control when you have even nonprofit players doing this?
Yeah, the medical arms race does not discriminate between nonprofits and for-profits. And that's why I think we have to have some overall limits for how much can be spent, certainly on Medicare. And I will say one thing about healthcare reform. There's nothing in that reform law, and those of you on Capitol Hill can correct me. I'm looking at Liana. There's nothing there to stop the increase in private health insurance premiums. I was watching Secretary Sebelius being interviewed in 2010 on ABC News, and the reporter was asking her, well, what happens if people get health insurance premium increases of 20, 30? Remember that was happening 20, 30, 40% out in California. And her reply was, I'll never forget it, well, they should go to their state legislature and governor and try to get legislation passed calling for rate review. So there's nothing in the health reform law that's stopping how much private health insurance is going to be costing people.
Is there a federal review if it's above 10%, if it's more than a 10% increase?
There's a federal review, but the feds don't have the authority. The states have that authority to regulate health insurance.
And of course, you've got the medical loss ratio. People say maybe that will bring down premiums, but we'll see.
We'll see.
We'll see.
We'll see.
On all of these fronts, we'll see how active the regulators are. Not a a real hopeful. So you mentioned the Steve Brill article, and I think that's really interesting because it sort of put hospitals in particular on the defensive. I think he sort of let doctors off the hook in a way, but I think hospitals are sort of feeling the heat right now. Maybe it's a moment of change, although maybe that's optimistic. But how can hospitals make a good faith effort to respond?
Well, I think what's important is that hospitals should be publicly reporting their outcomes. How well really are they taking care of patients? What is their infection rate for different kinds of procedures? There's, consumers got together and got legislation passed in about 27 or 28 states requiring hospitals to publicly report certain infections. And that became because, both Democrats and Republicans are affected by infections. And there's 100,000 deaths a year. It would take a little more than 3 years of all the people who die from hospital-acquired infections to fill up Arlington Cemetery.
Wow.
Think about it. And we'd need another Arlington Cemetery every 3 years for all the people who die of medical errors. And that's why a lot of consumers and patient advocacy groups have calling for public reporting of how are your outcomes? how well are you really taking care of us? You know, we have a colleague who's following a breakout of a very, very deadly infection in hospitals in Kentucky where 40 people have died in one facility. These things should be publicly reported. So that's one avenue I think that can be taken.
So I'm about to throw it back to the audience to ask some questions, so get them ready. I want to ask just one final question, which is that your book focuses on Medicare, but some might argue that Medicare is actually doing a better job, being a better steward of public resources than many of the other players out there. If they're doing so badly, what do we think about the rest of the world?
Well, I think it's a challenge when you have programs that are run both by federal and state governments like Medicaid is, and when it includes long-term care. There are many challenges, but I think I focused on Medicare because it's something that everybody will be touched by, almost everybody in their lives when they reach age 65.
Great. So I think our first question is going to come from Capitol Hill Village. Great.
Capitol Hill Village is a partner of something called Medical House Call. And,
Tell us who you are. Tell us who you are.
What?
Tell us your name and who you are.
Oh, I'm sorry. Mary Proctor. I was president of the Capitol Hill Village for 4 years, and I'm still on the board and very interested in this subject. And I've talked to the people that run Medical House Call. Now, I understand from statistics that 70% of Americans die in a hospital, nursing home, or long-term care facility. Medical House Call takes care of about, I think, 300 patients, and only 30% of them don't die at home. And they have teams of social workers and nurses, and they are going to be reporting back to the healthcare innovation people their savings over normal care of patients. They still are not paid properly for travel time or case coordination.
Right.
So I wanted to get your comments on this and whether you see any way that data from other experiments of this kind will have an impact.
Right.
And how.
Well, first of all, let me congratulate you on the work that Capitol Hill Village is doing to helping people get care that they need where they want, in the way that they want it. That's a great gift that you're giving to people in the community. And I think your outcomes of what you're able to accomplish is really quite extraordinary. And this is this is really patient-centered care and patient-directed care. When I was at the Robert Wood Johnson Foundation, we funded many, many wonderful projects. The challenge is, how do they become mainstream? And how do they fit in a larger system where everything is geared to doing more, more, more? I'm giving a talk at the Society of Critical Care Medicine in January. These are intensive care physicians. And they want me to come to talk about, and the title will be, Don't Just Do Something, Stand There. And the reason is, and I've had intensive care physicians come up to me in great moral distress about what they see happening to people in hospitals. I was talking to a gentleman who worked on Capitol Hill for many years, and we had this extraordinary conversation where he described the death of his parents at a certain well-known hospital in a way that was so devastating to him and his family. The intensity of it, not knowing what was going on, being totally out of control. And how do we migrate from that system to this? It's really, really challenging because the system is so geared to do more and keep doing more and not just standing there. And I don't have an answer because the healthcare system, as we saw from a recent study that was published, it makes so much money off of complications, off of infections. It makes money off of illness. We've seen tremendous projects on great birth outcomes for inner city women. Right here in DC, there was a wonderful nurse that made that possible, was running that program. In comparison, in a lot of other instances, women have terrible outcomes, very expensive births in hospitals. So we know how to do it right. But why doesn't the system do it? Because everything, in my mind, is geared to, I have a chapter in here called Bill Baby Bill. Just like we had drill baby drill with the oil, in healthcare it's bill baby bill. That's the mantra. Like in real estate, location, location, location. So we're building more hospitals. We're seeing a boom in some communities. I was in New Jersey, and there's a $1 billion hospital that was built. And they have to fill it up with people. So how do we turn that around? So I think it's great we have wonderful pockets of goodness. And people should look for them. This is my advice to people. Look for those pockets of goodness with good clinicians that are doing it the right way. And they're out there, and you can find them. And be aware of the mainstream system, which is really geared. And sometimes the mainstream, let me be clear, the mainstream system does some incredible work. In the past couple of months, I've met 3 people who had absolutely perfect care. Quick one. One was a guy who was driving along Interstate 95. He was deputy commissioner of health in his state. And he pulled over. He said, to himself, I think I'm having a stroke. And in fact, he was. He called 911. And he said, I was brought to this hospital. And he said, I had perfect care. And so we have these moments of real greatness in our healthcare system. But the price we're paying for it is really quite extraordinary and not sustainable. So thank you for what you're doing. Keep trying it. Keep the innovation. Keep trying to spread it. People will migrate to it. It's a great gift you're giving. But it's going to be very hard to turn around the system to produce only that.
Can people be taught to refuse treatment?
I think they can, and I would start with the easy stuff. With the easy stuff. So here's an example. I was giving a talk a couple months ago to a group of state legislators. And I was talking about overuse, particularly of CT scans. CT scans, get a dose of radiation with those things. And a gentleman came up to me afterward. He was the speaker of his state assembly. And he said, I go to my doctor every 3 months, and I get a chest x-ray every time. And I said, well, do you have any underlying, do you have anything going on? He says, no. And I said, well, what do you think about that? He says, well, I never really thought about the radiation. Next time I'm going to go, I'm going to talk to him. And so, and then
The executive physical?
no, this wasn't, going every 3 months is probably more than executive physical. But standing next to him was the deputy speaker of the state legislature of a big state in the Northeast. And he said, well, what about dental x-rays? Should I be getting them every year? I said, that's a really great question. What do you think? He says, well, maybe not. Maybe I should have a conversation with my doctor. And so what we're seeing is these are sort of easier things to help people.
Unless your doctor owned the X-ray and CT center, in which case having a conversation with them may not be so effective.
And then go on and do your homework and ask yourself, why am I getting this, and is the dose of radiation worth it? So where I would start with, yes, I think we can. And I would start with some of the easier things. I wouldn't wait to the end-of-life issues, because those are so profound. They're so emotionally laden. They're life and death. I would start with what I call the training wheel issues, on how to make decisions on whether or not to pursue certain treatments.
Great. Can we take other questions? Please.
There's been a lot of, some coverage at least, particularly I think by Patrick Grande, about hospitals where the doctors are salaried.
Yes.
Is that a possibility that could be broadened in the United States? Because it seems that the reporting has been pretty positive about that development.
Yes, about salaried physicians. I think it's a great step forward, and it's an improvement over the fee-for-service system we have now, where the more you do, the more you get paid. And it's not just salaried physicians, but it's systems that are really integrated, that are deliberate about the care that they provide to patients. They study their outcomes, and they take those lessons and they build it back into the system of care to make it better, constantly improving what they do. So I think they hold promise. The healthcare reform law tried to encourage more integrated systems with these accountable care organizations. But the reality is the vast majority of medicine is fee-for-service. In some cases, it's the Wild West. And it's like, training alligators. They're just not going to come in and do things differently. They are who they are.
Are there any hospitals in the D.C. area where, and you're willing to name them, where this kind of integrated care is more of a possibility?
The closest thing that I can think of is Kaiser MidAtlantic, and that's not an endorsement, but Kaiser Health Plan MidAtlantic is a health plan that is where physicians are salaried, and it's sort of like an HMO. It's a system of care. And I know that they have been trying over many years to actually make improvements. So I was actually at a Hill Center event, and someone was so thrilled to be enrolled in Kaiser because when they were over in Europe, they could email their doctor and get a response. And they thought that was great.
But of course, Kaiser, and I'm from California where Kaiser is the big player, their costs are very high.
So these are all the trade-offs we have to make. And when you've seen one system, you've seen one system. But your point about, yes, we have to move away from the system where physicians are out on their own fee-for-service. That said, now, more and more physicians are becoming salaried. They're becoming, they're integrating with hospitals. And it's a very interesting thing what's happening. Hospitals now are collecting an extra facility fee. So if you're a patient and you're on Medicare and you go to see your doctor today in his or her office, you pay a certain amount of money. You go back 3 months later, and during that time frame, the physician has had his or her practice purchased by a hospital. You'll go back to that same doctor, and if he or she has that arrangement with the hospital, you'll be charged a facility fee. And Medicare will be charged a facility fee because the physician now is working for the hospital. It's an added amount of money that will increase your copay. And yet the care you get is exactly the same thing. So as physicians become salaried and owned by hospitals, the price is actually going up.
And I would also add that it depends on the structure that the doctor's contract have. If the structure says the doctor will receive a bonus if they do more surgeries or they do more CT scans, you're mimicking the fee-for-service model with integrated system where there's a salaried doctor. So it depends on how they structure it.
And to your point, some of you might have seen the 60 Minutes segment a couple of months ago where there were 4 emergency room physicians who were interviewed expressing deep concern about the arrangements that their hospital that they were working for had for them. They were expected, they alleged, and they showed, documentation, but still an allegation that the hospital had set quotas for them for admitting patients on Medicare to the hospital. The goal was to admit for Medicare patients who were admitted to the ER. These ER doctors had a goal of admitting 50% of them to the hospital. And there were other quotas and, quote, productivity targets that physicians were expected to meet. So it's one thing to be salaried, but now we're seeing these arrangements that are really quite extraordinary, that are pushing the overtreatment agenda. Because as we know, overtreatment creates, more opportunities for billing. So we have to be very, very smart about our health care.
As we mentioned a little bit of the role of self-regulation in terms of addressing performance of hospitals and doctors, recently was recognition of the state medical person. Whether people realize how personally effective they are and how ineffective they are in many cases.
Oh, medicine is called a profession, and a profession is supposed to regulate itself. And yet we know that there's some wonderful physicians out there, and they do have some sense of self-regulation. But then there's a whole lot, then you have an entire population, and in its entirety it's not self-regulating. And that's a challenge. And that's why we have things called state medical boards that grant licenses to physicians that are supposed to regulate the practice, not the practice of medicine, but regulate the licenses so that physicians do act to improve the health of the public and aren't a danger to the public. And I think many people agree that state medical boards have not been very effective in that regard. There was this physician in Delaware who was found to be abusing children who was out practicing for years, and it wasn't until it got exposed that his license was revoked. So we have a real challenge in American healthcare to address the fact that there are some physicians who probably shouldn't be practicing medicine, or they should be practicing medicine in a very different way. And I know this is something that Public Citizen has worked on for many, many years to its credit, trying to hold medical boards accountable. It's a great public service, but it's very hard work, and they're completely underfunded. They're losing money when they should be ramping up their efforts to protect the public.
Of course, the Joint Commission, which gets made by hospitals to perform oversight over the hospitals.
Right, the Joint Commission is the entity that accredits many hospitals and other healthcare facilities in this country, and if nothing else, they provide a floor. So as someone said, when the Joint Commission comes, you make sure the elevators work. And in some hospitals and some communities, that's, that floor is really important. But it does not ensure that you're going to get high-quality, safe care.
Great. Sure.
Hi, I'm Leanna Orsolini, and I'm no longer on the Hill. I'm unemployed.
But looking.
But I was a health policy fellow in the immediate office of the Secretary of Health. And Medicare is, by the way, FYI, aware of that loophole about physician practices, and they're trying to close it. But I'm finding that there's always a workaround. So I've been hearing a lot lately on the voucher system for Medicare, and I'm gonna, I haven't read your book yet, but am I right to assume that because if we get rid of the fraud, waste, and abuse in Medicare, that we won't need a voucher system? Is that kind of, how do you feel about that?
Well, if we can get rid of that 30% waste in Medicare, we will have enough money to take care of everybody. And if we set some limits on growth, we can ensure that we have a sustainable system for certainly Jenny's generation and generations to come. About vouchers, I did some homework for writing Medicare Meltdown to find out what's it like now for people, and some of you might have experience in this room, of choosing among health plans when you reach age 65 and you become eligible for Medicare. And so I did a search, and there's 30 different health plans available in my area. And plus there's a whole bunch of Part D drug plans. And I think I know a little bit about healthcare, and I was completely confused. And I wonder what happens to everybody else. And they say this is in the name of competition. And it's causing more chaos. And there was a very prominent person who was head of a well-known organization here in D.C. that they, like the free market. And when this person turned 65 and had to sign up for Medicare, couldn't figure out what to do. That's not a marketplace that's working. And so, are we going to really expect people who are getting on in years to be able to get a sum of money and then make, and there might be some people who want to do that, but then to choose among competing health plans, and I know, Consumer Checkbook has done such incredible work to try to put information out there for federal employees and others. But it can be a really hard choice, particularly if in your 60s, 70s. When my mother was in her 80s, no way she could do it. No
Even
possible
for
way.
younger people, it's going to be difficult, and that's what I think we're going to see in the exchanges as well.
And the other problem I have with a voucher, because it puts the financial onus, the assumption is that seniors are on the front lines of cost control then, and I don't think that's a really fair thing to do, because seniors aren't really creating the issue. So consumers have no negotiating power as far as I'm concerned with a hospital. They have no negotiating power when they go to the pharmacy to pick up a drug. So I'm not really a fan of using vouchers in a marketplace for a product that, Nobel Prize winning economists have said, like Kenneth Arrow, healthcare is a different kind of commodity than any other kind of commodity. And I think I was reading a wonderful New York Times piece, and what do consumers want? They don't want a lot of chaos. They want something that they can rely on that's trustworthy. And we as a society, if we really wanted to, we could give it to them. The question is, do we want to? And how do we make that happen? I think we can do it if we really wanted to.
We have a question over here. Sorry, I forgot to say. Can you say your name and affiliation first?
Jay Lester. I just moved in here to D.C. from Texas, so I've lived in two different worlds. The other day I was at a meeting and a person said their professional group, which is from around the country, health professions, went to have a day on the Hill. And they said they were uniformly told in most offices or representatives and senators that if it was about anything to do with affordable care, the answer was no. And it was chilling. So my question is about poisoning the well for a real discussion about, as you said, sort of the tectonic plates that are crashed. So I was wondering, I haven't had the chance to read your book yet. Could you skip to the end and at least are you more optimistic? I mean, how do you see all this working out for you with the demographics and that rising expectations, increased complexity?
Well, it was the public that got that Affordable Care Act passed, because the reality of people not having access to health insurance to pay for health care, and that took decades to happen, but it took the public to say this is not acceptable, and it took to the point where 50 million people don't have insurance, that there were enough to say, gee, maybe this is something whose time has come. And I think we are seeing something whose time is coming about the price of health care. We just need an organizing entity. What's the collective action, and what will be the focal point and the hub for that collective action, where people will say, yes, we should know the price of these things, and we should also know the quality of it. We should know what the infection rates are at hospitals. I'm part of the wonderful work that Consumers Union has been doing. They have a Safe Patient Project, and they've gotten legislation, they've pushed for legislation on quality and patient safety and accountability. They're working on these issues. And that wasn't around, 12 years ago. And so we have made some progress, and we need people who are going to stand up and actually commit themselves as citizens to participate in our democracy. Democracy doesn't come cheap. Citizenry is more than just, saying I'm a citizen. We have to have an active role in it to serve as a countervailing influence to forces that, if we don't watch it, will take it in another direction. We are the checks and balances.
I think we have time for just one more question. Sure.
My name is Mark Gorman. I used to live on the Hill, but I've lived in Silver Spring for a long time. And I'm a cancer survivor, and for many years I've worked as a patient advocate. I have read Rosemary. Rosemary, I was particularly struck towards the back where you have the list of the 7 habits of an entitled healthcare industry. And when I first read that list, I thought, well, having read the book to that point, some feeling of discouragement because, the 7 habits all kind of are self-reinforcing. But after a while, I had a chance to think about it some more, and I realized, because you've talked about quality a couple of times, even though a lot of your conversation this evening has been about price qualities, that they are indeed interactive and self-reinforcing. Perhaps to the point that if any one of them were pulled out, there would be a ripple effect into the other remaining habits of the 7 habits. So that so you mentioned, an industry that resists scrutiny. Well, Bob and others have worked for years, and little by little, progress is being made on trying to, bring more sunlight into the dark corners. That is going to have a ripple effect. People who care about good government, one of the habits is the industry breeds corruption and it seeks protection from political elites. So, I thought eventually that there actually was a way for a fairly comprehensive political agenda that no one entity would need to take hold of every piece of. That people who are working on their particular issues could actually make a meaningful contribution to the whole because of how those 7 habits are self-reinforcing.
I think you have a calling in life, Mark. I think that's really a brilliant point. It's coming up with a strategy of how do we begin to address this as thoughtful citizens that want to see something different and better. And I agree. I think there are some strategic inroads. And I think the waste is a good one, because once you start asking the price of something, and you see how high it is, and then people, it'll be all over Twitter, it'll be all over the internet, and then you say, well, why does it cost so much? And that people will start probing and prodding, and then you'll be asking, well, what am I getting for it in terms of harm? And why am I paying for those infections? I interviewed a woman when I was doing the work on patient harm, and her husband went into the hospital. He was cleaning his gutters, broke his leg, hurt his back when he fell down off the ladder. And he got 3 infections in the hospital. He almost died. And they had this stack of bills coming to their house. And she said something so profound that only if you listen to patients will you really understand what's going on. She said, quote, "They harm you and they bill you for it." And so if we had price transparency, well, why am I, the next question is, well, why am I even paying for this? And you'll have a lot more, it'll open up a whole public dialogue that frankly the healthcare industry does not want us to have. Because once that opens up, it will be unstoppable. And you know, I'm not pro or con industry. I think the work that I've been trying to do over the years on safety and quality, all the people who've been harmed by errors who've been advocating, they're really giving a gift to the industry. It's a gift in the form of how to do it better. Because any industry works better when it has an ongoing dynamic and constructive tension with its customers, with the people that it's supposed to be serving. And for generations, the public has been kept out of healthcare. And so the common sense norms have not been incorporated in how it does its work. And I think we have a chance to change that by bringing more informed people into the dialogue. It's already happening. And I think we can do that on a broader way when we have things like price transparency, to begin to open up a whole different conversation about healthcare, about quality and safety. I think it's within our reach, and I think the time is right here in the United States to do that.
Thank you, Dr.